Hello, everyone. I'm Dr. Marty Ross, and this is another Conversations with Marty Ross MD tonight. It's a webinar where you get to ask about Lyme disease and you create the webinar with your questions. No 2 weeks are the same, so I look forward to seeing what you have in store for me tonight. I want to give everyone a warning. I've got a bronchitis that I'm getting over, and so it periodically causes me to cough. I thought about canceling because of it, but I thought, no, I wanted to give people help here. So just bear with me if I get into one of those coughing fits here, but hopefully not too much. And as much as I can, I'll try to mute the microphone when that happens too. The way that these webinars work, again, you create your question, create with your questions. You can write your question to me in the chat box, and that's down at the bottom. I want everyone to realize I will not get through all the questions tonight, okay? But give it a try, and we'll see if we get to your question or not. The other way you can participate in the webinar tonight is to see what the questions are that other people ask and see what the responses are that I give to those questions too, okay? I am creating a recording of tonight's webinar tomorrow morning. If I get up early enough, and I should be able to, I should have it all edited up and get it out to you in the morning along with the synopsis. I am starting to see patients here in Seattle, and so that's interfering with my free time in the morning to get this all done. In terms of seeing patients, I'm now doing, beginning this week on Wednesday was my first day of doing clinical consults. I'm not doing full medical care yet, and the difference is in a consult, you can visit with me online, and I will give you an opinion, but I cannot make a formal diagnosis that you submit to your insurance company. And I cannot, in that format, I cannot prescribe or write orders. The ability to do that is coming somewhere in November, December. I'm currently negotiating a lease on a new clinic space, and I hope that will manifest itself, although we've gone back and forth a couple times now, so we'll see. But if I do get that clinic space going somewhere at the end, mid-November to December, I will start providing what I call full medical service, which is the ability to diagnose, prescribe, and order test. Now, with those consult visits I was just talking about, even though I can't do all those things for you, I give you a note that you can use for your care, because I talk about a lot of herbal medicines and things, but also you can share it with your healthcare provider and see if they can help you with some of those prescriptions as well too. All right. And somewhere in the webinar tonight, I'll show you where you get access to that. Just be aware you can find it at martyrossmd.com. That's my clinic website. And go to the scheduling page or the appointments page, and you'll find out more about how I'm working these days. Okay. All right. So yes, I am back in Seattle. Good to be back here, and good to be among my good friends and family out here too. And yes, I have been following the Mariners, and I was actually at their loss last night, unfortunately, but hopefully they turn that around. All right. So without any further ado, let's go ahead and get started here. Hello, Thomas. Let's see. Oh, one other thing I should mention. If you're in the live version, you will see the question post on your screen. You'll be able to read it along with me, but it does not show up in the recorded version, so I will go ahead and read those questions, okay? All right. Thomas says, are you able to give time lapse from morning wake to night sleep, when to take things? I'm always confused about when to take binders, killing agents, supplements upon waking, before and after. I usually wake up, drink some lemon juice to help with digestion and get the bile flowing, and then I don't know what to take. Killing agents, binders, and in what order, before and after food. Thank you. So Thomas, without knowing specifically which things you're taking, it's hard for me to do that. I will make one comment about the timing of your binders, okay? So your binders are binders, right? So we're using binders in managing tick-borne diseases, especially when people have mold toxicity, all right? So in mold toxicity, the idea is that we try to remove those toxins from recirculating in you. So when somebody has mold toxicity issues, what happens is they are unable to break those toxins down the way that most of us would. Most of us, when we breathe in a mold toxin, our immune system sees that toxin, tags it, other immune cells come in and break it down, all right? But what happens in people with mold toxicity is their immune systems don't do that. Those mold toxins then get moved to the liver, and the liver doesn't process them correctly, then out to the gallbladder, and eventually out into the intestines where they get reabsorbed again. So we want to grab hold of those in the intestines, and we use these things called binders, of which a common binder I like using is a product by Biobotanical Research called GI Detox Plus, all right? But the problem with binders is they will bind up other medicines and supplements too. So the rule that I use for binders, you can take them anytime you want during the day, but here's the rule. So you need to basically, if you're on medicines and supplements, you want to make sure you haven't taken those medicines or supplements any closer than 30 minutes before you take your binder. And then you can resume taking your medicines and supplements 2 hours after your binder. Okay, so there's this 2.5 hour time period, which is stop everything, including basically your supplements and your prescriptions. 30 minutes later, you can take your binder. 2 hours later, you can start taking medicines and supplements again. All right. Now, food, you can have any time in that 2.5 hour window, but the ideal time to have food is 30 minutes after you take your binder. The reason that is an ideal time is that whenever you eat something, it causes your gallbladder to contract. And remember I said these toxins get stored away in your bile system and your gallbladder if you have a gallbladder. Well, you want that gallbladder to squeeze things out at the right time. And what happens when it takes cholestyramine or other binders about 30 minutes to work from the stomach down to the area of the small intestine where the gallbladder releases its stuff. And so you you take your binder, 30 minutes later, you eat something that causes the gallbladder to contract right where the binder is going by in the small intestines, okay? Beyond that, I can't give you any other guidance without knowing specifically what you're taking, okay? All right, sorry about that. Good luck to you, Thomas. First cough. We'll see if it gets too bad. I won't do the webinar, but hopefully I can hold off well enough that I can do the webinar here, everyone. All right, let's see. This is from Bill. Dr. Ross, I have the 3 Bs. What's the maximum dosage you would put someone on at the same time using rifampin, minocycline, clarithromycin, and atovaquone? How long would you put someone on all of these at the same time? Is it safe to use cryptolepis while using the medications listed above? Thanks, Bill. All right. So there is one issue I'm going to point out here, and I always remember how the interaction works, but there's an interaction between rifampin and atovaquone, and I often will not use those two together for that reason, but let me look more specifically at what that is. One of them elevates or decreases the level of the other. So hold on here a minute. Let's see. This is my drug checker. Okay, drug interactions. And what else are we going to put in? So we got removed. Add drugs. So we're going to do rifampin. And then we're going to add another one, which is the atovaquone. All right. This combination of rifampin and atovaquone may increase rifampin levels, causing potential side effects, and may decrease atovaquone levels, okay? So using this combination, rifampin may be able to go a little bit higher than normal, and the atovaquone may be a little bit lower than normal. For that reason, I often will not use the two of them together, but you still can. And if you were to do it, you would just want to follow your liver function test to make sure that the rifampin is not hurting the liver at higher levels. And you and then just see, are you responding to the atovaquone? Is it getting your Babesia symptoms to go away? Okay, so that's the only thing that I would say is generally I don't like doing that. I will occasionally, I have done it before and had success, but you have that drug interaction, interplay issue going on, okay? But having said that, the rifampin dosing I would do would be a total of 600 milligrams one time a day. That comes as a 300 milligram pill, so you would do 2 pills one time a day, okay? Minocycline, I would dose in this combination at 100 milligrams twice a day. Clarithromycin, I would dose at 500 milligrams twice a day. And the atovaquone, I would do a teaspoonful twice a day on that. Okay, that's where I would start. Now, if your Babesia symptoms aren't getting better, because again, rifampin may lead to lower levels of atovaquone, then after about a month or two, if I'm not starting to see some shift, some improvement in Babesia symptoms, then I might bump up my atovaquone more to overcome some of that rifampin effect, okay? All right. Could you use cryptolepis with this? Yeah, no problem at all, okay? So in general, you've laid out here, the rifampin, minocycline, clarithromycin would be a very good Bartonella treatment. The main thing that's missing off of that is you don't have any action against persister Bartonella, but cryptolepis would pick up the persisters, all right? So with both Bartonella and Borrelia, Lyme, we recognize that the germs are in a growing state, and some of them go into hibernation. We call those persisters. And these days, most of us are trying to have people take something that deals with persisters. The cryptolepis would do that. The rifampin, minocycline, clarithromycin would also be a pretty effective Borrelia treatment. And again, the cryptolepis would pick up the persister situation there as well. And then the atovaquone, clarithromycin, minocycline, and crypto, all of that in combination would be a good Babesia treatment. Keep in mind, we are not aware that Babesia has persister states. So just because I said that crypto works on persister Bartonella and Borrelia, there is no such thing that we are aware of in the world of Babesia. Okay, all right. So anyhow, Bill, I hope that answers your question. Good luck to you. Hello, Chris. Let's see. What causes shortness of breath and long COVID? How to treat? Any connection to vagus nerve? 2, started SPM active, and with 3 days of using it, I started itching. See that this can be an unexpected side effect. What should I take instead? Ideas? Could this indicate mast cell issues? All right, so good questions. Let me see if I can help with that. So the shortness of breath in long COVID could be due to a couple things. One, having had COVID, you could have had injury to your lung tissues. Okay, that's possible. But the other thing that's more likely is that you've got injury caused by COVID to the lining of your blood vessels. And that lining of the blood vessels is called the endothelial glycocalyx. There's good studies that show that COVID attached to the endothelial glycocalyx and that there was damage to it, okay? So basically so let me explain what the endothelial glycocalyx and how that might lead to shortness of breath. And then I'll talk to you about what you could do about that, all right? So first of all, your blood vessels have different layers, all right? There's a muscular layer. Inside the muscular layer is a layer of cells called the endothelial cells. And on the inside of those endothelial cells is this layer called the endothelial glycocalyx, all right? Now, what the role of the endothelial glycocalyx is it's kind of like a gelatinous layer that's got little hair fibers that stick up. So this would be like the opening where blood flows, and these little hair fibers get carried by blood movement. And when they get moved, that triggers those cells and the endothelial glycocalyx to make nitric oxide, all right? Nitric oxide is your blood vessel dilator, all right? So if your endothelial glycocalyx is working well, you get release of nitric oxide that causes small blood vessels downstream to stay open wider, to bring more blood with oxygen, or bring more blood in to pick up oxygen and then carry that oxygen back to your tissues. If you're not making enough nitric oxide, essentially, you get restricted blood flow, and restricted picking up of oxygen by the blood, and therefore you may feel air hunger as a result of that, okay? So what you want to do, there's a product made up of something called rhamnan sulfate. Rhamnan sulfate is an extract from a type of green seaweed called Monostrum nitidum. I love these names. And it's been shown to repair the endothelial glycocalyx. And the way that you wind up in the product that this is found in is a product by a company called Calroy, and it's called Arterosil, okay? And I have people start at 2 pills twice a day for a month. And then after a month, I would decrease it to 1 pill twice a day, at least for 2 more months to see if it's going to make a difference for you, all right? Now, I will tell you, based on starting to use it in COVID, I also came up with this idea based on how I know Bartonella works, that maybe Bartonella was causing some of the same injury, and that's why people were getting air hunger with Bartonella. And so I've been recommending Arterosil in that situation and finding some pretty good improvements as well too, okay, just from that, all right? I'll show you the Arterosil in a moment so you know where to get it, okay? But that's what I would recommend there. I don't think it has relationship to the vagus nerve, okay? The SPM active that you're talking about is fatty acids that come from fish oil, and there's a certain extract of fatty acids that are known as inflammation resolving factors, or we call them resolvins, okay? And one of the ideas in long COVID is that inflammation just gets overly turned on and that we need to turn it off. The resolvins are a way to turn that off, okay? The itching you're having could be you are allergic to something in that product, or it could be mast cell issues. We know that COVID can cause mast cell issues. So I would need to help me figure out whether it is mast cell triggered by the SPM active product, or is it an allergic reaction. I would need to know a lot more what was happening before taking it regarding what mast cells can cause, okay? All right, so anyhow, I can't answer that for you right now because you and I can't interact that way, okay? All right, so let me just go ahead and do a quick screen share here for you. Let's see, we'll do that one. Okay, so this is my Lyme disease information site and store. So it's Treat Lyme by Marty Ross MD, where you can find all the information you want about Lyme. You find my Lymeology guides here. As part of this, I have my supplement store, okay? And so the product that I was just talking about is made by Calroy Health Sciences, and it is this product called Arterosil. All right, and so that's what I recommend. The way that you can purchase it through my store now is you would just hit this buy at Marty Ross MD Phamologist store. I'm no longer processing your orders here. We have a partnership with a company called Phamologist, and you can buy it directly from a phamologist then, okay? The other thing I want to let you know is eventually we're going to have it so that when you click the buy now button over here, it will go right to the shopping cart for Phamologist, okay? All right. We see last week when we stopped sharing, it didn't release the screen each time. I'm hoping that's not an issue today. We'll find out. I'll know tomorrow. So when I try to do the editing, I know if it did not just release that big screen, you're still seeing me as a small area. But if it did release the big screen, you're seeing me as a big area. All right. So we'll see what happens with that. Good luck, Chris. Hello, Thomas. Let's see, are there any standard baseline supplements that anyone with severe Lyme should be taking? Potassium, magnesium, vitamin D, iodine, vitamins. How much will your consultation fee be? All right. So my consultation is, I'm recommending for people that I offer a 30-minute, 60-minute, an hour and a half. For people that have complex issues, please book an hour and a half. Give me the time to be able to help decipher things with you, okay? Especially if we have to go through a lot of history. Do not expect me to solve everything if you're complex and you only book a 60-minute visit, okay? All right? So just keep that in mind. Most people, what I'm recommending is they book a 60-minute visit, though, unless you have something that is a brief one-question item of which I might figure it out in a half hour after asking you questions. All right? All right. My fees are $682 for a 1-hour visit, $341 for a 30-minute visit, and then the 1.5-hour visit is $890. I do a little bit of a discount on that. Okay. Now, if you start checking around my fees, I know some of you may be thinking, oh my God, it is a lot less than the top tier docs that you would try to find out in California and out in New York, for instance. So it's reasonable within that context. Okay. All right. So yeah, anyhow, that's how you would do that. In terms of basic supplements that anyone, I think, should take, definitely, I like getting people on probiotics, especially if they're going to be on either herbal or prescription antibiotics. And if you have GI symptoms, I like a probiotic called Metabolic Daily, which is by a company called Pendulum, 1 or 2 a day. And if you don't have a lot of GI symptoms, I prefer using something called a spore-forming probiotic called Corebiotic. I will show you a whole article as to why I make that distinction between those two supplements, okay? But that's what I like to do. The other thing, I often like to work with a multivitamin, and the multivitamin I like using is a product by Research Nutritionals, which is called the Physician Daily. I think it provides a good baseline of a number of nutrients that may benefit people, especially if their diet has been compromised in any way, okay? For people that have, so those are 2 recommended things that I definitely think all people should be on as part of their treatment. And then based on other symptoms and what's happening, I may recommend more things than that, but that would be my starting point, okay? The Physician's Daily also has some vitamin D in it. It's got your minerals in it. It's got your B complexes in it, okay? All right. All right. So in terms of, I think that's it. All right. So let me just do a quick screen share here again. Okay. So, excuse me, everyone. So this is my practice website. And in terms of figuring out how I'm working right now and how you book appointments and everything, you would come to this appointments tab and you would pick this learn and book now. So you can learn about my visit offerings. When it comes time to actually visiting with me, you would click on the video platform to be able to go to my secure video platform, okay? But when you click here, basically I'm describing my opening timeline, which is basically I started taking appointments September 10th for my consult visits. And on October 15th, 2 days ago, I actually started doing them, okay? And again, I tried to make an explanation to you earlier about the difference between what's called an educational medical consult, where I don't prescribe and order tests, and a full medical service visit, all right? Now, full medical is where I do everything for you, okay? And for initially, I'm going to require anyone, even old patients, that after I open my clinic up, that to get full medical service, you have to come and see me in my office, okay? And that's because I need to please my medical board and tell them that I examined you, all right? Once somebody has seen me in my office one time for full medical, then they will qualify to do telemedicine for their follow-up appointments if they are a Washington State resident. For non-Washington State residents, unfortunately, you will need to fly back in and see me for each visit. And that is because after the pandemic, most state licensing organizations now are enforcing their laws that say, when I do telemedicine, I have to be licensed in the state where you are located at that time. So in other words, if you are calling me from New York City and you want advice from me, in terms of prescribing and everything, or actually prescribing, that means I need to be licensed in New York State, and I'm not. I'm licensed in Washington State. Okay, all right. So we also are requiring a security deposit, and then down here in this section, I try to describe in greater detail what I mean by an educational medical consult And what I mean by a full medical service, in here you'll find details about pricing, length of visit, and I want to point this out. These are all the required forms that you need to fill out before you come to see me, okay? When you're ready to book, you would click this button here, which takes you to my scheduling program, okay? All right. And at this time, we are only scheduling the consult visits. We are not scheduling anything else because I still have to identify where my new clinic location is going to be. I don't have a signed lease yet, okay? All right, let's see here. Thanks for that question, Thomas. Hello, Melissa. Let's see. Family treatment guideline question. For Lyme, how is the efficacy of cryptolepis and Japanese knotweed different than atovabark and cat's claw? A family of 6 is Lyme positive. The mom had Lyme, tick-borne relapsing fever, anaplasmosis, and Bartonella treated for 1.5 years to 85%. Then a massive Bart relapse with severe psych symptoms after moving. After 9 more months of treatment, she is at 80% again. She was infected for all pregnancies, but diagnosed years later after the kid's birth. 2 kids show moderate to severe infections with PANS, psych symptoms, but only tested positive for Lyme. They are under treatment and improving. Sidahukuda, Hutania, Japanese knotweed, crypto, cinnamon clove, oregano. The other 3 have mild symptoms and Lyme positive. What would be the best herbals for Lyme positive only with this family history? Should everyone use Otova, cat's claw, or cryptolepis, Japanese knotweed? With the mom and 2 kids relapsing after a move, would you consider mold even without the unknown exposures? Okay, so there's a number of things to unpack here. So first of all, I want to just raise something with you that I see in my practice. So 80% of the time in my practice, when somebody quote unquote relapses, I find that it is not really the Bartonella or the Borrelia or the Babesia that came back. It's actually that they have symptoms of worsening being caused by intestinal yeast overgrowth, okay? Keep in mind, most Lyme, most Bartonella, most Babesia symptoms are due to the immune system overproducing cytokines. And when you get intestinal yeast overgrowth from having been on your prescription antibiotics, and yes, even herbal antibiotics, although it doesn't tend to cause them as much, the biggest risk you have is developing intestinal yeast overgrowth. You can screen to see if that is what has happened by asking them simple questions like, have you had increased sugar cravings? Do you get worse overall when you have sugar? Have you had a breakout in your skin of pimples, acne? Did your eczema get worse? Did your psoriasis get worse? We see skin conditions, as you know, get worse with active yeast in the intestines. Women, do you have vaginal itching, vaginal discharge? Okay, so those are some things you can clinically use. But even sometimes when that's negative, if I can't figure out another reason for the relapse, sometimes I'll just treat for yeast anyhow. And I will tell you, 80 to 90% of the time that I see relapses, it's yeast. And if I just spend a good 2 months, 1 month, 2 months cleaning that out, most people get back on their way. The reason I'm raising that with you is you told me that as you treated this person's Bartonella, you haven't been able to get her all the way back. So I would wonder, is there still some yeast potentially as part of that? That's just a trick that I've learned along the way. Okay, so just keep that in mind. All right, now in terms of the herbs that are my favorite these days, okay, and I have used all of the herbs. I've written about all these herbs like the Otova and the cat's claw, but my favorite herbal combination that gets at Lyme, Bartonella, and Borrelia effectively, so you don't have to declare what germs the person has, because sometimes it's hard to tell. Okay, yes, I agree with PANS and PANDAS and the neuropsych stuff going on in the mom. There's a high likelihood of Bartonella as a cause here. I get that, okay? But you know, Borrelia sometimes can do the same thing too. So it gets to be really tricky sometimes to tease out which germ is active. So a number of years ago, before I moved to Austin, I had started using the combination of cryptolepis, Japanese knotweed, and the liposomal cinnamon clove oregano. It's just that, not all the other herbs that you mentioned here, just those 3. Okay. And what I like about it, how I came to that, is Johns Hopkins University had done some laboratory experiments looking at what would be effective against growing and persister forms of Lyme and Bartonella. And they had some pretty strong results with the cryptolepis. They had good results with Japanese knotweed, and they had done previous studies looking at various oils that would go after these persisters too, and generally the cinnamon, the clove, and oregano. Those all had good results as well too. So I started using that combination in my practice. My sense, as I introduce things and have worked with these, this is just a sense, is that of these, cryptolepis is probably your strongest. And then I find good activity from the knotweed and good activity from the liposomal cinnamon, clove, oregano, okay? So now crypto is active against Babesia. It's active against growing and persister Lyme and Bartonella. Japanese knotweed is useful at Lyme and Bartonella, growing and persister, according to the Hopkins experiments. And then your cinnamon, clove, oregano is interesting in that the clove part of that may have activity against Babesia as well. The Hopkins was able to show that these oils also are very effective at breaking down biofilm as well too. Okay, so keep that one in mind as well. Okay, all right, and then that combination is those three oils are effective against growing and persister Borrelia and Bartonella. All right, so those are just some thoughts for you. Okay, all right, good luck, Melissa. Hold on here, everyone. It looks like somebody was having a reception issue. I'm gonna just ask briefly, can somebody just, maybe a few, just write to me and tell me, are you hearing me okay? Is there a reception issue? Could somebody please write in the chat box and let me know about that? Okay, good. All right, everyone's still here. Good. All right, thank you guys. I know there's a little bit of a delay. Actually, I think when I talk, and I think it's about 15 to 20 seconds later than it received on your end. So I know it gets a little complicated here. So thank you everyone for responding there. Okay, good. All right, so hi, Eric. Let's see. Hi, Dr. Ross. For Borrelia, Babesia Odecoilei, Bartonella, all confirmed at TLabs. I was originally on Malarone, azithromycin, rifampin, about 5.5 months starting in February. Then my LLMD pivoted to clarithromycin and ceftonir for the last 7 weeks or so. My LLMD is now moving back to Mepron, tetracycline, and azithromycin. He is also considering Disulfiram. What do you think of this shift? I have Babesia Odecoilei. We are testing G6PD in case we use atovaquone in a few months. Thank you. All right. So let me just cover a few things here. So everyone, TLabs is a lab that was set up by Dr. Mosignani. Many of you may know him as one of our top Bartonella experts. And Dr. Mosignani has basically developed what we call direct testing. Direct testing means you actually see the germ, okay, under the microscope. The way that he sees it is that he's applying a fluorescent marker that attaches to the genetic material of the germ, okay? It would be similar to the FISH test, for instance, that IGeneX does, okay? Now, a direct test means you see it. You can't refute that. If you're seeing it, you see it, okay? It's there, all right? That compares with what we call indirect testing, which is antibody testing, measuring your immune reaction, okay? And we assume if you have an immune reaction against a specific germ, it must be there, all right? So indirect testing would be like the immunoblot that people get through IGeneX, or it could be what we call ELISpot testing, which is looking to see how active your T white blood cells are against certain germs. That also is another indirect test as well too. Okay, now, so what I would say is, yeah, you got solid evidence that you have got these 3 infections. Okay, now, okay, so for those 3, you were on 5.5 months of Malarone, azithromycin, rifampin. You know, that could have, the problem again, the rifampin in there would have decreased the levels of the atovaquone found within the Malarone. Malarone is a 2 combination medicine. It has a quinine derivative in it, as well as atovaquone. So you might have not had fully effective Malarone on that combination, just to make you aware. Okay, all right. But 5.5 months as means of treating Babesia, if it's Babesia microti, often that is all you need to do. But if you have Babesia Odecoilei, that is a more complicated animal. It takes months to even a year or more sometimes, okay? All right. All right, so then you said then after that, your LMD pivoted to clarithromycin and ceftonir for the last 7 weeks or so. All right, so that combination would have been only effective against Borrelia, maybe. And the reason I say that is the thing so that would have picked up intracellular Borrelia, would have picked up cyst or spirochete Borrelia. The only thing you're missing here on Borrelia is it didn't pick up the form we call a cyst forms. All right, so I would call that the strongest treatment you've been on. All right, now he's thinking of going back to Mepron, tetracycline, azithromycin, also considering Disulfiram. Okay, so Mepron is all atovaquone versus before you had a little bit of atovaquone within the Malarone. So it could be stronger. It may not be effective against Odecoilei though. All right, so if you are really thinking that the strain of Babesia you have is Odecoilei, I'm not convinced that atovaquone is going to get the job done. All right. The tetracycline azithromycin can help for Babesia. The tetracycline azithromycin is also very effective for Bartonella, and the tetracycline azithromycin will go after intracellular spirochete Borrelia, but probably again is not doing anything against the cyst form. Now, Disulfiram, I don't use it anymore. So Disulfiram's got mixed data on it as to whether it is useful against persister Borrelia. We never thought it was useful against persister Bartonella, and there is some evidence that it might help with Babesia, but it is very weak. And it's a risky drug. There is a large number of people that develop psychiatric problems that will reverse when you stop it, but there's also a subset of people that get permanent nerve damage from being on it as well too. All right. I think for the most part, a lot of us have just moved away from using it. I think we have other options like those herbal options that would work better. So do I think that the Mepron, tetracycline, azithromycin, Disulfiram might get the job done? Maybe, but I wouldn't call it the strongest way to go. Because there's a chance you have Babesia Odecoilei, that we're having the most benefit going after Babesia Odecoilei using treatments that are based on tofenaquine. All right. So I'm not clear why your provider just doesn't bite the bullet and go for it. Because I know, Eric, you've raised the question here a number of times, and I think your provider needs to move off and just do it. Okay. Tofenaquine is a good drug. You do need to check this blood level of something called G6PD. G6PD, everyone, is an antioxidant. And if you're low in this antioxidant in your blood cells and you take tofenaquine, it could rupture your red blood cells. So that does need to be checked first, okay? But when we look at probably our strongest Babesia agent against Babesia Odecoilei, it would be the tofenaquine. The atovaquone-based treatments are not working that well against it. As a backup to tofenaquine, if you cannot get it, I like using primaquine, which is in the same family. I find it works quite well. I know that there are some doctors that think that the tofenaquine is stronger. It probably is. But I find primaquine is a primaquine-based Babesia treatment is a good option as well, too. Okay? All right. So, everyone, all these things I'm talking about, I'm going to just do a quick screen share here for you. Let's see here. Somewhere here I'm doing a screen share. There we go. All right. So at my Lyme information site, as many of you know, I have different guides on how to treat different things. So I'm going to go to my infection treatment plans one here. So in terms of Babesia, take a look at my guide called Kills Babesia, a brief guide. And in terms of what I call these quinoline treatments, the quinoline treatments are tofenaquine and primaquine. They're in the same family, okay? And so here's how I start by using primaquine, and then here's some options that you could use to build a tofenaquine-based treatment too, okay? Let's see, go back here. Okay. Hold on, everyone. I'm going to mute here for a minute so I can just cough a good one. Sorry about that. Well, I muted this time at least. Yeah. All right. Good luck to you, Eric. Hello, Bill. Let's see. Hello, Dr. Ross. I was on primaquine, clarithromycin, methylene blue, cryptolepis for Babesia for a year, still testing positive on TLabs. 1 month ago, atovaquone and rifampin was added, have BART as well, but we're trying to target Babesia. Hold on, everyone. Just a minute. All right, let's see here. Liver and kidney function is monitored monthly. In the last 2 tests, ALK phosphatase was rising, but the second test, 150 normal range. Oh, and 150 with normal range of 40 to 129. I stopped the atovaquone and rifampin, retested 2 weeks later, and it's starting to come down. Would you restart this in case or give the liver a rest? If so, how long? All right. Bear with me here for a minute. You know, it's possible. So the alkaline phosphatase is a chemical that looks at that's made within the biliary system, right? Your bile duct and your gallbladder. It will get made if they're being irritated. It also can be made within your bones in a way that we will distinguish whether it's coming from bones or coming from the gallbladder is to measure something called a GGT. All right. And if the GGT is elevated, that can suggest that it's coming more from your gallbladder and not your bones. All right. Anyhow, that's how we kind of make that distinction. You know, your elevation, I would suggest, is not a harmful elevation at 150. And I don't know that I would have modified anything. All right. Now, having said that, I want you to be aware, as I made comments earlier tonight, that atovaquone is bumping up your rifampin levels. And atovaquone, I'm glad to see they're adding atovaquone here, but because of being on rifampin, you may need to increase the atovaquone levels to get adequate levels on that too, okay? So those are just some things for you to think about, okay? All right. Good luck to you, Bill. So to answer your question, I would have never stopped it. So I would have just kept doing it and followed your test. So I think you can go back on it now and just follow. They should periodically check and see what's happening, whether it's elevating or not. Okay. Hello, Christine. Let's see. I was diagnosed with Lyme in late August, but I've had it since late May. Western blot for acute infection, antibiotics present. Our son had long-term Lyme at a young age, so I know more about Lyme than not. My symptoms in May started with vertigo and progressed to joint pain, headache, extreme fatigue, fever and chills. then brain fog, confusion, forgetting things, which is what finally tipped me off. 2 questions. I was training for my first marathon when all this started, and in late May also developed Achilles tendonitis, which still hurts. I'm 47. Could this still be the Lyme bacteria in my Achilles tissue? I've seen the running doc and have done all the home self-care recommended. 2, how do you know if Lyme bacteria has crossed the blood-brain barrier? I've continued to have emotional and mental health ups and downs with Lyme, particularly, and have been on doxy for 6.5 weeks, along with herbals and other supplements or stronger meds potentially needed. All right. So, to answer your question, and actually, I was at the ILADS meeting, the annual Lyme Disease Associate or International Lyme Disease Society meeting in San Antonio this last week, Thursday and Friday, and then also the weekend, right? And there were a lot of presentations on neuro-Lyme this time around, and one of the authors presenting information that shows that within hours of getting a tick bite, Lyme has already crossed over into the brain. In other words, everyone has some neuro-Lyme. Now, that doesn't mean everyone manifests that neuro-Lyme the same, and some people don't look like they have neuro-Lyme, but Lyme goes everywhere, okay? So I just want you to know that, yeah, it could be everywhere, okay? And so it has crossed your blood-brain barrier. That's just the nature of the illness. All right, now let me go back here, see. The other comment I want to make, and then I'm going to try to answer your questions. IgM bans and positivity on a immunoblot or even Western blot for Borrelia and Lyme is confusing. And so in most infections, whenever you develop IgM antibodies, it's a sign that it's an acute infection, okay? And what happens in the way that antibodies work, when we first get sick with something, is the IgM family we develop first. At about 6 weeks to 3 months, the IgMs go away, and then our immune system starts producing IgG antibodies, okay? And those IgG antibodies may remain even after a germ is gone because they act as the memory of the immune system. There are studies that came out 20 years ago when the National Institutes of Health was conducting studies about the effects of long-term antibiotics to treat chronic Lyme disease. They funded 3 different studies, and to enroll in those studies, people had to have already gone through a Lyme treatment and not recovered. All right, so these are people that had Lyme for a while. And to get enrolled in the study, people had to test positive for Lyme and then have failed old treatment. So as part of getting enrolled, they had to do a current Lyme test. And the data showed that 50% of these chronic people that had failed treatment were still making IgM antibodies. We don't know why it happens. All right, we don't know fully sure. There's all kinds of theories, but IgMs can still be made from chronic infection, all right? Now, I will admit, and then there's we're starting to see things come out of, with IGeneX having developed its immunoblot testing method over a few years ago. We're now starting to see data coming out from there. And their data is starting to show that, yes, even in Bartonella, chronic infections can still produce IgMs. And we're starting to see maybe some of that evidence for Babesia as well, too. Right, so there is something going on with the immune system and chronic tick-borne infections and IgMs that we don't understand. But an IgM, the point I'm trying to make is IgMs can remain positive and be a sign of old infection, chronic infection, basically, okay? Now, I know that you had symptoms that started in May. And my question, if I was working with you in my office, I would try to help figure out, did you get an acute tick bite then, all right? Because your symptoms of joint pain, headache, extreme fatigue, fever, and chills brain fog, confusion, forgetting things. Does sound like acute Lyme to me, all right? Maybe even Bartonella, it sounds like, okay? So I was training for my first marathon when all this started late May, developed Achilles tendonitis. Could this still be Lyme bacteria in my Achilles tissues? So yeah, it could be. So keep in mind your connective tissues, which would be your tendons and your ligaments, have poorer blood flow, and it's harder for the antibiotics to get in there and do their job, all right? So Lyme likes to sequester itself, hide itself in tissues with poor blood flow. So yeah, it could be you still got some pockets of infection going on there, definitely. So what we do know for acute Lyme is when people get on 3 to 4 weeks of doxycycline for what is truly acute Lyme, they saw a tick attached, they got a bullseye rash, they got symptomatic, they got on their 3 weeks of doxycycline, about 20% of those people will fail treatment and go on to develop chronic Lyme disease, all right? So even though being on doxy was a good choice in this situation, it just may be you're in that group that is just not entirely working well enough, okay? All right. I would hope that you're working with somebody that's Lyme literate that can help you steer your way through this. It starts getting a little more complicated, okay? All right. Good luck to you, Christine. Hello, Mary. Let's see. Hi. Do you treat IgG, mycoplasma, EBV, and chlamydias? So that's an interesting question. I was at a talk this weekend. As I said, I was at the iLads meeting that maybe shifting my viewpoint on the EBV side of things, okay? But basically, here's the problem with mycoplasma and chlamydia. Those are bacteria. And those are bacteria that can be found regularly in healthy people. And when I say found, what I mean is we find antibody evidence that somebody's had those infections. And they're basically healthy, right? So we assume that those two infections are intracellular infections that can live in healthy people because their immune systems keep it under control, all right? So therefore, just finding that you have elevated antibodies against mycoplasma or against chlamydia does not mean that the germs have become active. It could mean that the immune system is doing its job and keeping them under control, all right? So I don't routinely check for them because I don't find it helps me decide if I'm going to treat, all right? Additionally, the antibiotics that we use to treat intracellular Borrelia and intracellular Bartonella, and those would be things like rifampin, doxycycline, azithromycin, clarithromycin, even the herbal antibiotics that we use are going to be effective against mycoplasma and chlamydia. So essentially, by treating chronic tick-borne infections, you're treating mycoplasma and chlamydia, even though I'm not clear you have to treat it, okay? Right. Now, Epstein-Barr virus is interesting. That's the monovirus, everyone. And it also is one of those infections that can be found quite often in healthy people, all right? So you have to ask, when you see elevated antibodies, is it that the immune system lost the battle, or is it that these things have become active, okay? So there's a physician that presented this weekend that has done a lot of work on helping people with long COVID. And in long COVID, part of the theory is that for some of them, they're getting reactivated tick-borne infections, and they're getting reactivated Epstein-Barr. And she presented data that shows that, yeah, people can get better if you go after these Epstein-Barr infections, especially in the COVID situation, perhaps within the tick-borne infection. Now, the problem with Epstein-Barr is we don't actually have antivirals that were developed to treat Epstein-Barr. We have antivirals that were designed to treat HIV. We have antivirals that were designed to treat herpes virus. And by that, I mean like cold sore herpes or genital herpes, okay? But no one actually went out and designed an antiviral viral to treat Epstein-Barr. Now, Epstein-Barr is in the herpes family, so some of my colleagues I know over time have advocated using the things we would use against herpes. And so she did present some data that was interesting in using Valtrex, which is also called valcyclovir, and using it at 100 milligrams 3 times a day, I believe for like 6 months or even up to a year, and people having some improvements in their status. So I need to go back and decipher that talk a little bit more, but it's an idea I may be exploring in my patients that are not showing good improvement after I go after their tick-borne infections. And I may eventually start going after Epstein-Barr. I historically have not. Now, there's another thing to keep in mind. One of the arguments I make about why you may not necessarily need to go after your chronic viruses is that one of the reasons they get active is Lyme and tick-borne infections suppress the immune system, okay? So that allows these germs to get activated. So one of the arguments I've always made is, well, go after the Lyme and the tick-borne infections then, so that the immune system turns back on and starts dealing with these chronic viruses and even your mycoplasma and your chlamydia, for instance, okay? So I think there's a part of that too. So what I can tell you is, I think the way I'm going to go is my approach always has been, don't even start looking for chronic viruses until about 6 months to a year if somebody's not getting better, all right? And if they're not getting better, then it may be time to address them. And usually I've been addressing them more with herbal options. I think I may switch that up to a Valtrex-based option in the future, okay? All right. Thanks, Mary. Good luck to you. Hold on here, everyone. Let's see here. This is from Dawn. Hello, Dawn. Let's see. Dear Dr. Ross, thank you for all you do. You're welcome. I have been dealing with persistent Lyme disease since 2002. I have been on your protocol for about 4 months using the Montana Pharmacy herbal tinctures, cryptolepis, atovaquone, and cat's claw. I was able to tolerate those fine until I started a medication, Keppra, for another problem, which I have now discontinued. But the Keppra aggravated my stomach so much that now I cannot tolerate the tinctures. I'm trying to get a handle all the gut and stomach issues, but it's complicated. I may have a hiatal hernia and ulcer, don't know yet. I tried steeping the herbal tinctures in hot water. I enjoyed that, but they were still too upsetting for my stomach and aggravated reflux. I have discontinued the herbal tinctures for now. Is there another way that I can get the herbs into my system that work almost as well? Maybe even an oral route or non-oral route. For instance, I use estrogen cream topically. Could I mix the tinctures with DMSO? So, Dawn, I don't know that you're going to get absorption of the active ingredients of those things. I just don't know. All right. There's a couple of things you might want to consider here. So with gastritis and with reflux, sometimes you can help soothe the stomach lining by using deglycerated licorice. So deglycerated licorice is a form of licorice that has a chemical group removed called the glycyrrhiza group. And you remove that because if you leave it on, it may lead to high blood pressure, okay? And if you chew licorice tablets and before you try taking your herbs, basically what happens is chewing the licorice tablets interacts with your saliva, and the saliva and licorice together forms a microscopic gelatinous coat that covers your food pipe, also covers the stomach and the stomach lining. Okay, all right. So you get a layer of protection. All right. And in fact, what I will tell you, there's some evidence that it could be an effective way of treating stomach ulcers as well too. So what you might consider doing is spending a good week of chewing up 2 to 3 of a product called Rhizonate. I'll show that to you here in a minute. Maybe 3 times a day before meals. Do it for a week. Then after a week, before you take your tinctures, chew the tablets again for about maybe wait about 5 minutes, 10 minutes, and then try your tinctures. But I would steam off the alcohol. Okay, now something else to consider is if you find that the tincture variety doesn't work, because sometimes it's the alcohol in there that is irritating. And when you steam off the alcohol as you did, you get most of the alcohol off, but you're not getting all of the alcohol off. Okay, so another option to consider would be to do that rhizonate option like I discussed, and then maybe try to go over to capsule forms of the cryptolepis, okay, and of your otova and your cat's claw. Now, off the top of my head, I don't know the correct dosing of the capsules. And what I usually wind up having to do is look up one of the various books that that Buhner wrote. Many of you may know Buhner as being a master herbalist. He left the world a couple years ago, I believe, and I think maybe it's been longer than that, but his books are still out there. So if you were to find Buhner herbs, he's got a book on Babesia, he's got one on Bartonella, he's got one on Borrelia, and in there he usually will give directions on the amount of capsules and even gives recommendations where to get those capsules, okay? So you might want to look at some of the Buhner books and see if you can get some ideas if you need to go to the capsules, okay? All right. Good luck to you. Actually, just in case y'all don't, so many of you may not know Buhner anymore because as he's passed, he may be becoming a fading thing within the world of Lyme. Let me, all right, so let's look at, I just do it this way. I'm going to go to Amazon. Okay, so these are the Buhner books. So this is, they have them all listed out here. So he's got one on Bartonella mycoplasma. He's got one on Lyme. He's got a number of them. And he also does have a anaplasma Babesia one. Okay, so anyhow, take a look here. These are my reference books that I use when I'm looking at getting dosing ideas. Okay, all right. And Buhner, for some reason, if this screen share did not work, his last name is spelled B-U-H-N-E-R, and his name is Stephen, S-T-E-P-H-E-N, and the last name is Buhner, B-U-H-N-E-R, okay? All right. Hello, Jason. Let's see. I'm managing what I believe is Bartonella and a little nervous to take lemberclinase. Do you ever suggest working first with the less potent enzymes first? Also, is there any risk of taking a probiotic with leaky gut? Thank you. I understand. So on the probiotic question, so everyone, leaky gut means that you've got gaps in your intestinal lining. Okay, so what happens is your intestinal lining is made up of inside of the intestines. You've got a mucus layer called mucin that covers the intestinal cells, and then you have these intestinal cells that lock together very tight without any gaps between them, okay? All right, now, this mucin layer is a layer of protection that keeps things from penetrating that shouldn't get through, all right? That is maintained by a probiotic called Akkermansia. Akkermansia actually makes mucin and lays it down, okay? All right? And many of you have heard tonight, I've recommended Akkermansia before, okay? All right, or maybe not tonight, but in other webinars I have, okay? Now, what happens in leaky gut is due to yeast infections or something that wears down this mucin lining, and maybe even Lyme and Bartonella, these immune cells will pull up, or these intestinal cells will pull apart, and you get gaps, okay? Now, in normal intestines where you don't have gaps, the way the architecture is that you have your cells, below that you have 70%, 60 to 70% of the body's immune cells sit here, and then you have your blood vessels under here, okay? So in healthy functioning intestines, you get digestion of food up in the intestines, you get micro digestion of food into its amino acids and proteins and sugar by the bacteria that line here. And it gets so dissolved that and then those small particles get absorbed into your cells, pass through the cells where they get into the blood vessels, all right? And the immune cells won't react against these components because they're just sugars, proteins, and fats. That's it, okay? Now, in leaky gut, when you get these things pulling apart, you wind up getting partially digested food that still looks like it came from corn or it came from broccoli. I don't know if anyone had broccoli allergies before, or it came from cheese, okay? And suddenly these things get through and the body starts reacting because it hits all these immune cells down here, 60 to 70% of the body's immune cells, of which some of these are mast cells, your allergy cells, okay? And it triggers them and they go off, okay? So that's what leaky gut is, things leaking through, okay? All right, now, is a hypothetical, and I'm gonna call it a hypothetical concern, that these gaps will allow your probiotic bacteria to get through and you get into bacteria infection into your blood. To be honest, I understand the theory behind that. I just haven't seen it happen. And in all these years, I'm sure most of my patients have some degree of leaky gut when they come to me. I use probiotics all the time, and I have not found them to cause any problem. And I haven't seen any literature that says this is a problem. So in other words, I think you can use your probiotics, okay? That's my opinion on that, okay? And then in terms of the lumbar kinase, in terms of there have not been good studies done looking at the various enzymes, okay, in terms of what's the most potent. We as clinicians have an impression, and I'm going to call it an impression because when I've tried to go back and find the science on this, it's just not there. We have an impression that lumbar kinase is your strongest fibrin protein breaking enzyme, fibrinolytic, okay? Probably less potent would be a nattokinase, and I think most of us think it is quite a bit less potent. I think you can give a nattokinase a try, all right? The other thing I do is I just usually will just have people open up their lumbar kinase sometimes and have them even dip their finger into it and go ahead and take a small amount, okay? So the other way you could do this is just take small amounts of that lumbar kinase, okay? All right. Good luck to you, Jason. And thanks for that question. Hello, Melissa. Hold on here a minute. All right. So is there a way to accurately test your house? I don't think you mean hose. I think you mean house for mold, or only the urine test through real-time lab? Okay. So there's two issues. Okay. So first of all, when you're doing urine testing for real-time labs, you're trying to see, are you a person that is not able to remove mold toxins once you breathe them in? Okay. Now keep in mind, 75% of us could live in a house loaded with mold and producing mold toxins and not accumulate mold toxins in our blood because our immune systems will break them down. This problem of mold toxicity is only an issue for 25% of people, all people, whether they have Lyme or don't have Lyme, okay? So when somebody does have mold in their, that they pee out, because it's being filtered from the blood, mold toxins, then you want to know, are they living in a place that's poisoning them, okay? And the way you do that is to get, the best way, I think, is to do something called an ERMI test, which is looking at mold spores within dust samples, okay? I think most of us that treat probably think that's the stronger way to go, all right? So that's the accurate way that I would do it, is to get an ERMI test, E-R-M-I. You can even get the test kit yourself if you want to. And the only time I advocate doing that is if somebody actually has mold toxins that we can measure in them by doing the real-time test, all right? Because again, it doesn't matter what's going on in your house. Well, it does to a degree, but it's a major issue if you're a person that cannot eliminate those mold toxins, and 75% of people can. Okay? All right. Thanks for that question, Melissa. If you want to read a little bit more about this, let me do a screen share here. Let's see here. So this is my article on mold toxin illness and Lyme disease, okay? All right. And this gives you all the information you need. Excuse me, everyone, hold on a minute. Oh boy. I hate to do this, everyone, but I'm starting to have trouble again. My voice is starting to go too now. I think I've just spent an hour with you, and I think I'm going to call it early tonight just because of this thing I got going on that I'm hoping I get some recovery from here soon. So I've enjoyed being with you for the last hour, and keep an eye out tomorrow morning. I'm going to end the webinar now. I'm tired of coughing and trying to soothe everything here. So keep an eye out tomorrow morning in your email. I will send out announcement that the recording is ready to be seen. I am back here with you again next week. Hopefully all this stuff is resolved. And so please, in that email tomorrow morning, you'll get a link to sign up for the next webinar as well too. Okay. And any of you that are interested in getting consults, I showed you earlier tonight, you can find how to get a direct consult with me at martyrossmd.com on the appointments page. And I'm booked out a number of weeks now, but we still have space. So feel free to do that as well too. All right. All right. Good night, everyone.